Why do we need ABC pathway?
Atrial fibrillation is the commonest heart rhythm problem, but we recognize that atrial fibrillation patients have higher risk of stroke and also of all-cause mortality. Now, if we look at mortality, well, of the mortality related to atrial fibrillation, only 1 in 10 is stroke-related. More than 7 out of 10 of the mortality in atrial fibrillation is cardiovascular. The ABC pathway basically is to try and streamline the management decisions, and this is across the board from, for example, general practitioners who look after the most patients with atrial fibrillation, hospital doctors or specialists such as the cardiologists, but also the non-cardiologists. And thirdly, the patients, because the patients need to understand the principles of why atrial fibrillation management is important. What is the ABC pathway? It basically brings together what we are doing in everyday practice, but to make sure that whether general practitioners, hospital specialists, or the patient can understand why we're doing this. A is avoid stroke with anticoagulation. So A is avoiding stroke and is the use of anticoagulants, and that's to prevent stroke. B is better symptom management, and this is therefore related to patient-centered, symptom-directed decisions on rate control or rhythm control for atrial fibrillation. And the C stands for cardiovascular and comorbidity risk factor management. This includes managing the many risk factors often associated with atrial fibrillation, such as cardiac ischemia, heart failure, hypertension, sleep apnea, for example. Also includes the lifestyle aspects, weight reduction, regular exercise, cutting back on alcohol and stimulants. And finally, the patient, psychological morbidity related to atrial fibrillation that is well recognized amongst atrial fibrillation patients. If we are going with a very simple A, B, and C, we therefore have a streamlined pathway that can be understood whether it's the general practitioner, the non-specialist, or the specialist cardiologist, and of course the patients.
What are some practical points or actions that can help clinicians to implement the ABC pathway in daily practice?
Implementation of the ABC pathway is very simple, and we have already rolled this out to our local clinicians and looking after patients, and this relates to even colleagues in primary care or general practice, and also within the hospital, both specialists and non-specialist cardiologists. Patients leave my atrial fibrillation clinic understanding the principles of their management, which the message we give to them is as simple as A, B, and C. Now, how can we make this simple? Well, it's firstly in the discussion with the patient that what the priorities of management, avoiding stroke, which is A, managing their symptoms in a better manner, so it's better symptom management, and C, their comorbidity, their risk factor management. And in fact, it is so simple, our general practitioners have put this into a simple one-page pathway that is laminated and sent out to all the general practitioners. Therefore, it's just the principles of management in a patient pathway that is easy to understand, and it's a very simple message how we can holistically or manage atrial fibrillation in an integrated manner that is uniform across all practitioners.
Do you think it will be possible to evaluate the ABC pathway in a large randomized clinical trial? And what do you think would be the strengths and limitations of this type of trial?
The ABC pathway is simple and practical, but of course it's no point coming up with a simple and practical concept if we can't evaluate its implementation. Well, firstly, we have implemented this in relation to some of our local general practitioners and colleagues, but we've also started a program of research to back up the evidence for the ABC pathway. We presented one of the first of the outputs as a proof of concept study, and this was a hotline presentation at the recent European Society of Cardiology meeting, and the paper was also concomitantly published in the American Journal of Medicine. And this was to look at a post-hoc analysis of a clinical trial cohort, and this trial was done in the era of warfarin. So A, avoid stroke with anticoagulant. We look at warfarin quality control, and we were aiming for a time in therapeutic range, or TTR, above 70% as an indicator of optimal management. B, for symptom management, we compared the patients who are no or mildly symptomatic versus those who are polysymptomatic in relation to their outcomes. And for C, this is obviously multiple comorbidities. So for example, with blood pressure, we looked at blood pressure targets of under 140/85 and the use of cardiovascular prevention drugs such as statins, ACE inhibitors or angiotensin receptor blockers, beta blockers, and so on, and in relation to cardiovascular prevention. And this post hoc analysis, ABC compliant patients compared to non-ABC compliant patients, those who are ABC compliant as part of the pathway had a significant reduction in mortality, a significant reduction in hospitalizations, and a significant reduction in the composite of mortality, cardiovascular mortality specifically, bleeding, and hospitalizations. Now, this is obviously a post hoc proof of concept study. We have taken this forward with some population-based studies, and the results will be published or presented soon. And we are undertaking a large randomized control trial, and this is in addition to smart technology using smartphone apps, and this trial is underway. What are the challenges? Well, the challenges are clearly to make sure that colleagues managing these patients use the ABC pathway in a uniform manner, because we can only, of course, give the optimal targets for certain things. For example, if it's a warfarin-taking patient, to make sure that they're reaching a certain time in therapeutic range. If it's a patient on a NOAC, a non-vitamin K antagonist oral anticoagulant, is to use the drug according to the label and according to the dose. In relation to, for example, cardiovascular risk factors, we can of course recommend blood pressure targets and to recommend cardiovascular prevention drugs for the particular condition, but ultimately it's the implementation. Nevertheless, with an ABC path, with the era now of smartphone technology and electronic health methods to facilitate this, we very much hope that the outcomes of the trial, which we will know in the next couple of years, will translate to a tangible benefit for managing patients with atrial fibrillation.